Welcome to the Healthy Heart Show, where we pull back the curtain on conventional medicine and dive into the root causes of cardiovascular health. If you are concerned about high cholesterol, high blood pressure, heart attacks, stroke, or atrial fibrillation, this is the place for you. We will provide natural heart information that will help you prevent, treat, and reverse any ailment, leaving pills and procedures out of the picture. Here are your guides to holistic heart health, board-certified cardiologist and Amazon best-selling author, Dr. Jack Wolfson, and natural heart doctor, naturopathic physician, Dr. Lauren Latanza.
Hello, I'm Dr. Jack Wolfson, natural heart doctor. Welcome to another episode of the Healthy Heart Show. And this one is absolutely going to be just a mind-blowing experience. I've got Dr. Stavrakis here, fresh from his trip back from Greece, and he's here to enlighten us on some really cool technology, but then also talking about the dynamics of how the brain and the autonomic nervous system impact cardiovascular health and wellness. And as always, I've got Dr. Lauren Latanza here, naturopathic medical doctor at Natural Heart Doctor, and I will let her do the intro. But first, let me say hello to you, Dr. Stavrakis. Great to see you.
Hello, great to see you too, Dr. Wolfson and Dr. Latanza. It's my pleasure to be here and share my experiences with you and with your audience.
Fantastic. All right, Dr. Lauren, take it away.
All right. So we've got a great guest for you today. So glad you're here, Dr. Stavrakis. Dr. Stavrakis is a clinical electrophysiologist and physician scientist at the University of Oklahoma Health Sciences Center. He is an associate professor of medicine and the director of cardiovascular research. He has been routinely performing complex ablations for the last 10 years, and his research has focused on autonomic neuromodulation for the treatment of atrial fibrillation and heart failure in both animal models and in humans. His work over the last 10 years culminated in a first-in-human randomized clinical trial examining the chronic effect of non-invasive vagus nerve stimulation in patients with paroxysmal atrial fibrillation, which was presented as a late-breaking trial at the recent Heart Rhythm Society scientific sessions in May 2019. His goal is to continue to explore the role of autonomic nervous system in cardiac arrhythmias and provide his expertise in both clinical procedures and research activities. Huge, tremendous work. So we have a lot to learn from you here today.
Thank you very much. It's my pleasure to share my experience.
All right. So let's just roll right into it. So first and foremost, what led you to becoming a cardiologist?
Well, I was fascinated by the complex physiology of the heart. And I had a great influence by my mentor, Dr. Ralph Lazera, who unfortunately passed away 4 years ago. But he inspired me to become a cardiologist like him.
Mm-hmm. And then how within that did you develop an interest in atrial fibrillation and the autonomic nervous system?
So again, I trained at the University of Oklahoma, and there was tremendous work in the field of autonomic influence to the heart. Ralph Lazera, Ben Sherlock. These were pioneers in this work, and I had them as mentors, and I got led into this exciting field.
Let me take it from there and ask you, I guess, if you would give us the 101 of the autonomic nervous system, the brain-heart connection, kind of as you see it.
So the brain controls the heart function, and the heart gives messages, multiple messages to the brain. So it's an interactive relationship. So one influences the other to fine-tune the heart function beat by beat.
So as we look at, the autonomics, I guess we talk about the sympathetic nervous system as part of that, the parasympathetic nervous system as part of that. And everybody right now, they're all in this sympathetic overdrive, right? I mean, it's this sympathetic tone. We're all under stress. We are all angry. We are all depressed. We are all in this fight or flight mode. And how much would you say that kind of, if the autonomic imbalance, or again, this high sympathetic tone, underactive parasympathetic tone, how would you say that plays into AFib?
So AFib is unique in the sense that you need both ingredients. You need both sympathetic and parasympathetic to make AFib. Other conditions like heart failure, they are characterized by heightened sympathetic tone and diminished parasympathetic. So, and this has been shown for AFib in both animal and clinical studies. Like before the onset of AFib, there is a surge of both sympathetic and parasympathetic tone. And we've shown in the lab that if you mix the two together, you're more likely to get AFib versus one or the other alone.
Oh, so it's more of a wow. So it's really just kind of this whole autonomic, surge.
Yeah, you're right. So it's different from heart failure. So in heart failure and other conditions, even diabetes, there is a constantly elevated sympathetic tone. But with AFib, you may be in the normal state with balance, and then for some reason you get an imbalance. Like for people with vagal, what's called so-called vagal AF, you eat a big meal, and there is high vagal tone, and you already have a little bit high sympathetic tone. You get a surge of both, and that's it. You get AFib.
Is there a percentage you could label on people? Like what percent of people are maybe more of that parasympathetic driven AFib? Like you said, they get it after a meal, after a bowel movement, after urinating, or maybe even they suffer from nocturnal AFib, right? They wake up in the middle of the night. Yep. And they go into it. So percentages, parasympathetic versus sympathetic versus a combination?
Combination. I would say the majority is combination. Vagal, it's about maybe 10-15%. Sympathetic, where they get it with peak exercise, is another 10-15%.
Are there certain pharmaceuticals that you find benefit the parasympathetic version? Those people that do it happens after a bowel movement, after a meal, or awakens them up for sleep. Should we be considering different pharmaceuticals in those people?
It hasn't been specifically studied for those people. And so not really. I mean, unfortunately, we use the one size fits all approach because of the current knowledge. I mean, we could do better if we were able to study in each patient their specific mechanism. But, we use antiarrhythmics. As you know, we use, flecainide, propafenone, Sodalo, amiodarone, you name it. But we use them irrespective of the mechanism, which is wrong, but we don't have a good way to study the mechanism of AFib in the individual patient.
Yeah, in my experience, in my training, we talked about those people with what appeared to be vaguely driven AFib, just based on their symptoms and their story that went along with it, that we would use the old Norpace, a disopyramide, because of its vagolytic effects. But again, I think that may be more theoretical and may not have much kind of evidence behind it. Would you agree?
Yeah, it's not used anymore. Plus, it produces QT prolongation. So we went away from that.
What do you got, Dr. Lauren?
All right. So what led you to study the PARASIM device?
So PARASIM device, that was, I would call it serendipity. What happened, we did a proof of concept study with a custom-made tragus stimulation device. And we showed that in people who came to the EP lab to have AFib ablation, when we stimulated their tragus it was just custom-made device. It was a clip, basically, and something like an alligator clip. The AFib duration was significantly reduced after 1 hour of stimulation. And that was done before any ablation was done. It was, during the preparation time. So at that time, we were looking to expand this study to ambulatory patients with AFib. And got an email from this company in Finland who were developing this device to treat tinnitus, ringing in the ears.
Oh, okay.
And I said, are you interested? We're trying to expand. Are you interested in testing our device in your AFib population? That's great, of course. So that's how it started. And we tested the PARASIM device in our clinical trial, which you alluded to. This was the first in human randomized clinical trial of non-invasive vagus stimulation for AFib.
Awesome. And so what results did you find?
So we found that overall, the median AFib burden was reduced by 75% at 6 months in the overall population. And the AFib burden is the percentage of AFib that, or the percentage of time people spent in AFib during the 2-week monitoring time that we monitored them. We didn't monitor continuously. That's one of the caveats of the study. We could have seen a larger effect had we monitored continuously.
I mean, that's obviously very impressive. I mean, that's better than pharmaceuticals. That's better numbers than ablation. I know all the ablaters like to think that they're the best in business and they've got super high success rates, but right, most of the data, at least that I've seen, right, it's 50% success. Maybe you can dive a little bit deeper into some of those numbers.
Yes, I can give you the numbers if you want. So we're talking just to put things or clarify a few things. The 50% you mentioned is AFib versus no AFib. So 50% will have no AFib. So our population, our metric was a little bit different. It was I would say maybe a non-traditional metric. It was AFib burden. So AFib burden is actually becoming more and more of a traditional metric, but the common metric of AFib success or procedural success rate is sinus rhythm maintenance, or percentage of people with no AFib at all. So that's where the 50% comes in. In our population, we had 75% decrease in the median AFib burden.
Were you surprised by those numbers? Were you surprised by the success, or do you think that some of your preliminary work that you had been doing prior to that really showed you that this is likely going to be the result?
Yes, the latter. So we were expecting to see something of this result. Now, the magnitude surprised us a little bit, but in a good way.
Okay, so now you publish this data, right? And now it's like, here's Dr. Stavrakis, and he's on CNN, and he's on Fox, and he's the keynote speaker at the American College of Cardiology meetings, right? Because this is incredible stuff.
Well, true, but as you alluded to, we're going against the mainstream, right? We are advocating a different, an alternative treatment, which doesn't cost a lot, doesn't make money for the hospitals. So there is some resistance to uptake it.
I'm not sure that I alluded to that, Stavros, but since you put it out there, people who know me, I would certainly be in agreement. Come on, give me a little more detail on this. Like, why can our patients not get the PARASIM in the United States?
Just before I say this, I will say that to our surprise, there was kind of a bimodal response in the patient population we studied. Half of the patients responded very, very well with almost complete elimination of their AFib over 6 months. The other half did not respond. And so some of the skepticism of the cardiology community would come from this caveat. We don't know. I think we don't know who's going to respond and who's not. I think we need better patient selection. We need a biomarker of response. So that's one thing. Now, why the PARASIM is not available in the US? That's, it depends on the company. It's a small company and they pursued approval, but the FDA needs more data. So we are in the process of, designing the new or the follow-up study, which would have more patients. It will be multi-center study. It will be up to FDA standards.
Okay, so I mean, before I go back to some of the things that we just said there, what is the downside of the PARASIM? What is the downside again of that, that tragus, stimulation, that low-level tragus stimulation that you said? And was there any signals or any kind of risk that you saw in your study?
I mean, we didn't see any risk related to the device, and by FDA designation is a non-significant risk device. So what I tell my patients is that, worst case scenario is not going to work, but there's not any harm in trying it.
Okay, so I'm going to make a statement and then you can agree or not agree. And I think you did allude to that before. The way I see it, again, is that the FDA is not approving this device because it works so well, it may render the ablation model, I guess, it may decrease the number of ablations that people go through. It may decrease the number of pharmaceuticals, of course, that are used. Like you said, it is a cost-effective, no-risk technology, but in the world of conspiracy theories that pharmaceutical companies, all the electrophysiologists, all the device companies that are all predicated on the current cardiovascular AFib treatment model, they are conspiring against doctors like you and this cutting edge technology. And it's a very sad situation.
I think that's an extreme statement. I agree 100% with that. And to clarify the FDA's position, what the FDA said was that the metric we use, the AFib burden, is not the standard one. And so I think subconsciously, electrophysiologists would prefer to be doing ablations and not compete against something else. Because right now, with the current evidence, ablation is the best treatment for AFib. And I say that, with full honesty and looking at the data. I don't have any personal bias. This is the truth. This is the data we have now. The ablation is the most successful therapy for AFib. How I view autonomic modulation is as an alternative approach. I don't think we should look at it as competing, because AFib is a progressive disease, and at some point you may do your PARASIM or the autonomic modulation, because you can use other devices as well. And at some point, it may not be effective. I mean, there are a lot of things we don't know, like what's the 5-year, I mean, we did a 6-month study. What's the effect in 2 years? We don't know.
The Healthy Heart Show will be right back after we take this quick break to hear from our sponsor. Would you like to drink great tasting coffee that's also good for your heart health? Cardiology Coffee is your answer. This 5-star rated coffee is delicious. It's a gourmet coffee that begins with whole organic beans, hand-selected and carefully roasted. It's tested and certified to be free of pesticides, mold, and other toxins. Cardiology Coffee is great for your heart, and you're going to love how it tastes. Order now online at cardiologycoffee.com. Now back to the Healthy Heart Show.
Are there other centers that are interested, obviously, in this technology and in collaborating on papers and research? Like, to me, outside of what I said, and I say plenty of things that are outside of the mainstream, and I'm certainly not going to hold you to that, Dr. Stavrakis. You're here, obviously, as an expert, really just talking about autonomics and about the PARASIM and about your study, and that's all anybody should take from this. My theories and stuff like that are my theories, but, again, how do we get more people? Because your study was so compelling, and it really also just makes kind of fundamental common sense about how, if we address the autonomics and autonomics dysfunction, autonomic insufficiency, and if we improve on that through a variety of mechanisms, and that can be dietary, that could be lifestyle, and it could be device-based therapies. right? As far as, getting collaborators on really pushing this forward.
Yeah, and we have an established collaboration with UCLA. We published a study together on the role of neuropeptide Y as a biomarker for patient selection for response to autonomic modulation. We also have a collaboration with MGH in Boston, and I know Duke, they're interested as well, Indiana University, to name a few. So I think we have those centers that have a tradition in studying autonomics. They're very interested in this technology and in this concept.
Excellent. Before I let Dr. Latanza ask a few more questions, let me ask you just as an aside. Now, this is a total side break here, okay? Does the fact that you are originally from Greece and your primary language, I assume, is Greek, your native language is Greek, how much advantage did that give you in medical school? Because all of the terminology and all of the roots of medical terms come from the Greek language. Was that kind of like cheating, or what do you think? You had the advantage.
In a way, it's cheating. There's a big advantage. I mean, I would say 50% of the words are purely Greek. You can see the same, even the spelling is, we're talking about dynamic, right? The term dynamic or sympathetic, sympathetic. Why we do write sympathetic with Y? Because the Greek is with epsilon, which is the equivalent. So
what about the word dysfunctional? Is that also, that's coming from Greek?
Part of it. Because whenever you see
dy,
whenever you say dys, it's this in Greek. That means bad, something bad. Now, function comes from Latin. So there are a lot of words that are mixed. The first part is Greek. The second part is Latin.
Yeah, but didn't the Latins steal it from the Greeks anyways?
Sometimes, but not all of the words. We have to give them some credit.
All right, I'll leave it at that.
So if you know both Greek and Latin, you can fly through medical school.
So future med students, add that to your list of prereqs. Pick up Greek and Latin.
Yeah,
right. I knew neither. It's kind of like they talk about as people travel around the world. What do you call someone who speaks many languages, right? Multilingual. What do you call someone who speaks two languages? Bilingual. What do you call someone who speaks one language? American.
Yeah.
All right, Lauren, tell me, what do you got?
All righty. So we kind of hit on this, but maybe if and when PARASIM will be available in the US, and are there other devices besides PARASIM that kind of might be hitting the market if they're not already there?
So actually there's, answer the second one. There are a lot of devices for transcutaneous vagal stimulation. There is a device called Gamma Core, which you have to hold in your vagus nerve. That's already approved in the US. There is a device, it's approved for opioid withdrawal. Again, transcutaneous device, and it's FDA approved. And there are even other devices that are not FDA approved, but are either in development or approved in Europe. Oh yeah, there's a device called NEMOS. It's a German device used for epilepsy. So lots of devices. As far as the PARASIM device, when is it going to be approved? I think that's going to take probably at least 2 years.
Mm-hmm. Maybe changing the metric on some studies.
Or even more.
Why can people get it in Europe then, as opposed to here? Yeah.
Because European regulations, you don't have to say you don't have to show efficacy to get approved. You just have to show safety. So anything that's safe, like PARASIM, can get approved. The FDA, on the other hand, requires both safety and efficacy to approve a device. So it's different regulations.
European makes a little bit more sense. Maybe just starting with something that's less invasive, seeing if it doesn't work, then try something more invasive, but having that as a frontline option. Let's see, any other recommended vagal strategies that you can offer to us and our listeners?
Of course. So exercise is an endogenous vagal stimulation therapy.
Like
Chronic,
aerobic is
and I'm talking about chronic, exercising chronically, because, if you are completely deconditioned, you haven't, you're a potato couch and you haven't done anything, and you start exercising strenuously, that actually activates your sympathetics. But, if you take it slowly and chronically, you increase your vagal tone. That's, it's actually called endogenous vagal stimulation. Endogenous is a Greek word again. It means intrinsic. So other strategies, people do meditation, do yoga. Again, those are ways to bring up your vagal tone. Deep breathing is another way. I wouldn't recommend it because it can make you dizzy, brings down your CO2. Those are the main strategies, like non-pharmacological and non-device.
And otherwise free to the patient.
Yes, free to the patient.
Let's see. Is there any role for PARASIM with persistent atrial fibrillation? So I don't know if that held a place in your studies or maybe in the future.
Yeah. So, the role of the autonomic system diminishes as the AFib progresses. So if you're going from paroxysmal to persistent, the influence of the autonomic tone and the autonomic nervous system goes down. So my feeling is that it's not going to be as important or as useful in persistent AFib. And I say my feeling because we don't have any data. We excluded on purpose. We excluded patients with persistent AFib in our study.
My thoughts on that was that, and why I wanted to ask that question were that, is there a way, obviously, if we were going to cardiovert someone, and therefore it's like, we're almost using PARASIM prior to and leading up to cardioversion, would it be more likely to have, lead to a successful cardioversion and then, of course, the maintenance of sinus rhythm? But, I would assume that's not something you've necessarily definitively looked at.
No, we didn't study that. Again, it depends. The problem is that we don't have a good way to assess the impact of the autonomic nervous system in the individual patient. Let's say, this is 50% autonomically driven and 50% substrate driven, like fibrosis of the atria and things like that. We don't have a good way to do that. And so some patients may benefit from this approach because they may still have a high influence of the autonomic nervous system. But on average, I don't think it will be very beneficial.
Okay.
And what does the future hold for low-level tragus stimulation in the research within that?
Yeah, so we're doing a lot of research. Our goal is two things. One is to define and find and identify some biomarkers of response, which will enable us to better select patients for this therapy. So these are the mechanistic part. Mm-hmm. The other part of our research effort is to expand our preliminary study to a larger study using the knowledge we gained from the first study and also from the second study that I just talked about, the mechanistic study, and perform a multi-center study with more patients, which will lead to eventually approval of the device.
Excellent.
What about Uzo and AFib? Yes or no?
In moderation, yes.
All right. I mean, it's interesting. Alcohol according to the literature, as I see it, people, alcohol drinkers up to a certain point enjoy lower cardiovascular mortality. But most of the research, although there is some maybe some newer stuff that's saying a little bit differently, to me, the stuff I've read, it's just alcohol. And I enjoy drinking alcohol. I don't drink it that often, but nonetheless, is that it's just like a linear, line. As alcohol consumption goes up, so does AFib risk.
That is true. So you pick your evil.
Pick your poison.
You want to have AFib and less cardiovascular mortality, or you want to avoid AFib but maybe be on the higher side of the risk on the curve, on that J curve.
Mm-hmm.
Well, I think your patients, my patients, those that suffer with atrial fibrillation, I think those people are more than happy to abstain to see if that certainly makes a difference.
Yeah, I think that's a fair statement. If you don't have AFib, drinking will probably not may benefit. I mean, in moderation, but if you have AFib, the more you do to decrease that risk, the more benefit you get. And talking about, lifestyle modifications, losing weight is an extremely important way. There's a great group in Australia led by Prash Sanders that showed us that losing weight, about 10% of your weight, decreases the risk of AFib recurrence by 40%. It's amazing.
Yeah.
Yeah.
Definitely significant.
I mean, certainly one of the things we do in our office, Stavros, is that, we just try and teach people is that if you're going to go for an ablation, can we make you the healthiest version of you prior to the ablation, so it is of that most success rates. And so you're right, by losing weight, by physical activity, by mindfulness, by all these healthy lifestyle changes. Now, a lot of times maybe people are suffering and they just need to get something done ASAP. But I think, once again, if we can get people the healthiest version of them, and if that doesn't take care of the AFib, then there is the ablation. And again, it's much more likely to be successful and also much less likely to have short-term risk and obviously long-term risk as well.
You're absolutely right. Yes, that's exactly the approach. The current approach to cardiology, to AFib management, follows the ABC protocol. A is anticoagulation. B is better symptom control. But the C, which was recently added in the 2020 guideline update, is comorbidities. So addressing comorbidities, we came to recognize that is equally important to anticoagulation and rhythm control.
Are the cardiologists enacting those new ABC guidelines, or are they just still stuck in the A and B?
I think it's easier to stick to the A and B portion, but I think we're lagging behind as a community. But in order to address the comorbidities, and I'm not just talking about obesity, but holistic approach, diabetes, hypertension, sleep apnea, all this, you need a multidisciplinary team. So, and it's been shown that if you manage AFib with a multidisciplinary team, you get better outcomes compared to a traditional, single cardiologist managing AFib.
Love it. That's what we teach over here, my friend. Dr. Stavros Stavrakis, it was an absolute pleasure. Thank you so much for spending, time with us. And we look forward to getting more updates and finding out kind of what you're up to and some of the cutting edge technologies that you're developing. And again, hopefully, just like anything, kind of conspiracies, aside and stuff like that we really make sure that we have the best and safest technology available to everyone around the world. And that's obviously what our goal is. So again, thank you for your time. I'm Dr. Jack Wolfson for Dr. Lauren Latanza. Another episode of the Healthy Heart Show in the books. We will see you next time. Cheers to your 100-year heart.
That does it for today's episode. Thanks so much for listening to the Healthy Heart Show. Please help us get the word out by liking and subscribing to our podcast and our Facebook page, Natural Heart Doctor. Please show support for our podcast sponsor, Cardiology Coffee, your resource for organic, antioxidant-rich, mold and pesticide-free coffee shipped straight to your door. Learn more by adding @cardiologycoffee on Instagram and visiting cardiologycoffee.com. This podcast provides materials for information and educational purposes only and should not be considered medical advice. We encourage you to contact your physician for any of the health issues discussed here.